Hi.
Gentlemen,
Hello.
welcome to Fireside Chat 2016.
So excited.
For those of you who don't know me, I'm Dr. Blake. And I've been asked to speak about precipitous deliveries and postpartum hemorrhage today. Start with the easy one, precipitous deliveries. Merriam-Webster dictionary definition of precipitous is very steep, happening in a very sudden and quick way, done too quickly and without enough thought or planning. All of the above. One of the interesting things looking at this is a definition, a fairly consistent definition of precipitous labor, but I think what we're probably more interested in precipitous delivery. Labor is the precipitous labor is defined as 3 hours or less, somewhat arbitrarily, obviously, and they quote an incidence of about 0.3 to 1%. Risk factors for delivering precipitously, morbidity, prior history of a precipitous delivery, prematurity because of the small size of the infant, if you think about the 3 Ps for delivery, passenger, passageway, and power. All of these things can be sort of affected by those factors. Abruption, substance abuse, particularly stimulants like cocaine, tachysystole in association with induction of labor. Complications of a precipitous delivery, maternal trauma, particularly vaginal perineal. Postpartum hemorrhage is associated with precipitous delivery. Neonatal concerns, including the need for resuscitation, and then there's the all-out hospital. That's probably the number one concern of patients who've had a precipitous delivery in the past is, am I going to make it to the hospital? And certainly, it does result at times in interventions like early induction, which then puts them at risk for precipitous delivery. So, brown shorts in the car on the way to the hospital. So the goal of trying to manage a labor and a delivery like this is an atraumatic delivery of the infant, obviously. Trying to avoid maternal trauma, understanding the mechanisms of labor and delivery, and then management of the third stage. When you look at what happens during labor, it can kind of help you to sort of decide what you're going to do at the time of delivery, and the mechanisms are flexion, internal rotation, extension, external rotation, or restitution, and then delivery. In the circumstance where you're managing that, first of all, I think Andrew and I both have talked about this and agree that the vast majority of anyone who's working in labor and delivery is very capable of managing the circumstance. In fact, it commonly happens outside of the hospital. And when I'm talking to patients about this, I always tell them, listen, if the kid falls out, you're going to be okay. So again, trying to minimize trauma, because again, typically these kids are firing out of there. You really sort of actively can help manage that with a few very simple maneuvers. And one of them is just pressure. And if anybody's ever watched me try to teach a resident how to do a normal vaginal delivery, I mean, the key is just some pressure on the occiput to make sure that it doesn't, again, come firing out of there, and realizing that it's going to extend, or extension is the first mechanism coming under the pubic bone. So what you don't want to do is have the kid fire straight out, because that's putting the perineum at risk. So again, I typically try to use my fingertips, just apply backward pressure and let it ease out by, again, with flexion. Because flexion will, or with extension I should say, that will hopefully minimize the diameter. And then the second area that's always of concern are the shoulders. Again, in the usual normal delivery circumstance, once the head is out, you let it restitute to whichever side it's going to restitute to. I tend to try to use 2 hands, sort of almost like you're getting a snap on Tom Brady, and just direct that whole unit slightly downwards. You don't want to pull. That's the worst thing you can do. And again, these kids are coming up quickly anyway, so they're probably not going to have to do much with the shoulders. But in general, you want to keep the neck and the shoulder girdle stable so that you're not flexing like this. And then just downwards till you see the front shoulder, and then upwards is the next key, because again, if you come straight out, you're going to go through the perineum, and that's where you get the lacerations. when they talk about management of the umbilical cord, I mean, you don't need to do anything. You can just leave it alone. I mean, if you have a clamp there, obviously you guys would have clamps available, put them on and cut it, it's no big deal. You don't have to. I mean, hopefully the placenta can come out and the cord does not need to be clamped. I mean, it's going to spasm on its own. So, you know, depending upon what else is going on, you can just totally leave it alone. Most of the time, obviously, you're going to clamp it and cut it. If there's a tight rupal cord, you know, again, kids will deliver through that. You know, they're going through a loop sort of thing. You got to sort of untangle them when they come out. But if the baby's precipitating, if it's coming out quickly like that, you don't necessarily need to reduce an umbilical cord. It'll deliver through it. If it's too tight and it doesn't seem like it's going to come, I mean, again, anteriorly, I usually slide a finger underneath the cord and then two, so that you can get a clamp on there and cut in between. Again, most of the time these kids are firing out of there anyway. Management of the third stage will connect us into our next topic, which is postpartum hemorrhage. Pitocin is always a good thing in the third stage. So if the individual does not have an IV, then it's just IM PIP. I think you should take the bottom of the bed off, personally, because there's nothing harder on your back than doing this. If you're worried about it, put the under buttocks drape under there. That'll catch the kid if you drop it.
Yeah, it's true.
You know, I know nobody does that. Everybody's afraid of taking the bottom of it, but just take it off. I mean,
There's always
okay.
more than one of us there anyway. I mean, chances are we're not going to drop it.
Right, and I mean, and that's the other thing. That's the other thing comes to then, do you sit or stand? I mean, that's, you know, and if you're not sure, sit down and you gotta laugh.
Yes, that's right. That's right. Yeah.
But I really, they can be, and you know, the thing is,
Yeah, that's what we're afraid of.
That's what we're afraid of.
stop and get, right, you know, but just,
Little
yeah.
chalk, you know.
But it's so much easier to be properly managing things with the bottom of the bed off. So I mean, I would never chastise anybody for coming, because now I gotta come in and
Yeah.
stitch as it pulls out or whatever. Any questions on that? You can all do it. You don't need to call emergency room physicians who know what they're doing. If there happens to be somebody else on the unit, that's great, but you can all do it. All right, so the more involved topic today is postpartum hemorrhage. Definitions are somewhat cloudy, but I mean, there's a clear thing about primary versus secondary or delayed or late. The first 24 hours is a primary postpartum hemorrhage. After that, it's officially a secondary or a late or a delayed. Everybody knows how difficult it is to get a number as far as what exactly is happening bleeding-wise. And as far as what entails a postpartum hemorrhage, I mean, there are definitions, but it's pretty vague. There's nothing black and white about this circumstance. Almost always in studies that have been done where they actually very carefully weighed and measured the amount of bleeding that has happened, it's almost universally underestimated, which I think we're all guilty of. Normal bleeding following a vaginal delivery is 500 cc's or less, and normal bleeding at the time of a cesarean section is 1,000 cc's or less. Very arbitrary, but that's the definition. I think what's most important is if you think there's excess bleeding, there usually is. And you know, so and then obviously if the patient becomes symptomatic. So if you think that somebody's got excess bleeding, they probably do. And if they start to get dizzy and lightheaded and pale and hypotensive, they certainly do. Incidence is somewhere around 1 to 5%. Major, especially worldwide, major cause of maternal mortality, not just morbidity. Most of the times it's treatable. So this is an area that certainly in a developed country like us, I mean, we really should not be losing patients or having major morbidities, except in the very unusual circumstances. I mean, this is a cool number. I mean, can you imagine 700 mils a minute is the circulation to the uterus, which is phenomenal when you think about it. And it's 15% of the pregnant patient's cardiac output at term goes to the uterus. So that's how they get sick. It was described to me as the uterine tourniquet is how most of the bleeding postpartum is controlled. The small blood vessels in the myometrium actually course through the smooth muscle fibers, and when contractions happen, those blood vessels get tourniquet. So that's why most people don't bleed to death from a giant placental site that's receiving 700 cc's a minute. Also, clotting factors go up while you're pregnant, both locally at the placental site plus in the circulation. And disturbances in either of those two mechanisms or bleeding from a laceration are the major causes of postpartum hemorrhage. Blood volume goes up 50% in pregnancy, so there is a little bit of a mechanism of safety there. Red cell volume does not increase as much as plasma volume, so that's why women are anemic at the end of their pregnancy. So acne is usually what happens. Other things like trauma, vaginal trauma from a vaginal delivery, or bleeding at a C-section, and then rarer things like DIC, or somebody has an inherent coagulopathy. That's almost always acne, and acne is the first thing you should be thinking of. So I know I reread our postpartum hemorrhage protocol, or whatever it is, and there are things that we can look for when the patient walks through the door that might put them at increased risk for having this problem subsequently, and some anticipation and preparation is always a good thing in this circumstance. So high parity, uterine overdistension, twins, polyhydramnios, think about it with diabetes, obviously. A past or a family history of postpartum hemorrhage. Morbid obesity is a risk factor by itself. Hypertensive disorders, so the preeclamptics, certainly if they have HELP syndrome, which ties into the coagulopathy, DIC, and then abnormal placentation, things like placenta previa, that kind of thing. So these are things that when the patient walks in the door, and again, some preparation in advance of that is not a bad idea. Things that can happen sort of once they're here and or intrapartum. Induction of labor is a risk factor. Prolonged or precipitous labor, I should say. Retained parts, obviously. Lacerations, instrumental delivery, which obviously leads to a higher incidence of episiotomy and lacerations. Large for gestational age infant. So again, the uterine overdistension. So suspicion, again, if you think she's bleeding too much, she's bleeding too much. Symptoms, so the patient becomes symptomatic from hypovolemia, and then careful ongoing assessment once you establish that this is something that you're concerned about. These are symptoms associated with blood loss. Volume on the left-hand column, blood pressure in the middle, that's systolic. And then, what you can expect the patient to be doing. This is not black and white. Rest, palpitations, lightheadedness, tachycardia, sweating, passing out, getting up to the bathroom and not making it, all those things. So as far as managing this condition, understand it's not terribly uncommon. Try to get an assessment of the individual's risk when she comes through the door. And I think we have a scoring system on our protocols. Active management of the third stage. So that's Pitocin. Again, well documented, clearly confirmed with well-based studies that Pitocin, a lot of places try to give it with the anterior delivery of the anterior shoulder, certainly as soon as possible once the insulin is delivered. Reduces the risk of both excessive bleeding and postpartum hemorrhage requirement management. Early identification and intervention. So again, suspicion is the number one thing. If you think she's bleeding too much, again, she probably is. Identify that and get moving on the management from that point onwards. Team effort, call for help, call the physician. This should be a joint effort, and certainly while we're instituting our initial measures for resuscitation and management, notification needs to go out to get help and get the appropriate resources mobilized. ABCs, so fluid management is the first thing. Hopefully they have an IV. If they don't, they need one. If they have a small IV, they need a large bore IV or more than one. And then once the resuscitated measures are in place, you obviously look to try to correct the etiologies. Again, apnea being the by far the most common. So Pitocin, fundal, and they talk about bimanual massage and go over the potential for the fundus being firm but the lower segment not. Bimanual massage is very easy. You put a hand into the vagina and you can actually squeeze the uterus between your two hands. And again, what you're trying to do obviously is stimulate those myometrial cells to contract and become a tourniquet. As blood loss assessment, again, if you think there's an excessive bleeding situation going on, you need to start to quantify forward catheter for urine output to ensure that you're getting urine output. And then, again, the initial steps here are for apnea, and then if that's not working, you got to start thinking about other things. But usually, again, by this point, hopefully the physician is around.
Should we do that by manual? Oh, no,
I don't think it's on. If somebody's hosing, yeah, I don't.
Because usually we're
you know.
rub their the
Well,
top
can't
of
you
it,
hold?
one could be going underneath and one could be doing the top.
No, it's usually one.
One
Because
shot
you
feel?
can get a better feel.
Oh, so you could feel
You
the
can
top
actually-
and,
yeah.
I mean, I wouldn't do it but sometimes I've come
I
to
mean,
the
if
point
it's
where I
life,
really need
if
to
it's
do it.
life-saving, yeah, you can. I mean, the other thing you can evacuate clots. You know, sometimes you get in there, and even though again
Yeah,
the fundus can
yeah.
feel firm, there's clots sitting in there.
We
and,
seem to
you
be
know,
afraid to go in there and do anything
Yeah.
until
Well,
you get there and then you do it, but if we
Yeah,
need to.
which is usually my job, but
Yeah,
I mean,
but sometimes you're at the office or-
if we're a distance away, and that seems like I would never
Okay.
fault anybody for doing that.
All
I
right.
mean, you want to be careful, obviously, of the
Well.
perineum and vagina, but when it's not a hard thing to feel once
No.
you're in there. And,
Yeah.
you know, and again, you can actually do uterine exploration at the same time, but. You know, for you, I mean, again, there's a couple of different, there's the crede and there's a couple of different maneuvers from a fundal management thing, but I mean, basically you want to just rub the thing
That's
and
what,
get it
well,
to
that's what we
track.
usually do. I
Yeah.
mean, is there something else we should do besides rubbing?
No,
No, just rub.
Yeah.
I mean, normal, okay.
yeah,
Yeah.
vigorous, as you know.
Yeah.
And the same thing with the catheter. I mean, the urinary catheter I mentioned about, you know, output, but it also, again, everybody knows it might be in the way. The bladder sometimes gets in the way of
Yeah.
uterine contraction, so it's not a bad idea. Even a red rubber, you know, at some point to get that out of the way. So additional uterotonic drugs, again, Pitocin, and they actually, I have a resuscitation algorithm here from Texas that is not much different than what we do, I don't think, but you know, they actually use a fairly significantly higher concentration of oxytocin. They use 15 units and 250 mils, so that's like more than double what we do. But again, there's nothing wrong with that additional fluids in the initial stage of the resuscitation for volume depletion. So again, that's usually the sort of order in which we attack things. Methogen, remember, if they're hypertensive or they have Raynaud's or something weird, it's not supposed to give it to not too many people with postpartum, which may be hypertensive. Carboprost is contraindicated with people with asthma, and then misoprostol is third on the list. You know, so again, you can work your way through those things.
We don't have that on the floor, do we, the carboprost?
That's
Hemorrhage.
Oh, Hemorrhage.
Yeah.
That's hemorrhage.
Can
I
you get
think
that
we
off?
did.
Yeah.
I think we did.
I'm glad you asked that.
Yeah, thanks for asking that. I planted her.
Yeah.
Misoprostol can be given without an IV. Methogen is IM. So all these things can be given without intravenous access if you don't have one yet. And then we get into okay, now we got a massive hemorrhage / transfusion, and you get everybody rolling. Send off labs to look for DIC, fibrinogen levels, that kind of thing. notify the blood bank that you've got a potential for needing blood products in large quantities. Everybody starts with packed red cells and then fresh frozen plasma. Resuscitative protocols vary in the ratio. A lot of people these days are recommending 1-to-1, so for every unit of red cells, you're getting a unit of fresh frozen plasma. Anywhere up to sort of 1 to 3, depending upon who you read. Might be needing the operating room, both for evaluation and exploration, but plus surgical management. DNC repair lacerations, and unfortunately sometimes laparotomy. You know, this can happen while you're in the midst of a C-section, so you're already in there. Again, even in that circumstance, you're going to mobilize the blood bank and make sure that everybody's on board with what's going on. Some of you have had experience with the vacuum balloon, which is sort of a tamponade method. It's been described as being used with both vaginal and C-section deliveries. Again, we're getting down to the list of, we don't want to go there, but it can happen. So sequelae, death, obviously, that's a bad outcome. And we try to avoid that if we can, but people still die from this, believe it or not. Hypovolemic shock and all the organ system failures that can go on with that, which again is why early intervention and vigorous resuscitation is important to try to prevent some of this. You can get DIC either from a pre-existing condition like preeclampsia, or you can get a dilutional DIC, which becomes apparent you know, once the massive hemorrhage is going on. Complications from resuscitation, transfusion complications, adult respiratory distress syndrome, surgical complications. If you end up, you know, with laparotomy and or a hysterectomy, you can sterilize somebody, you know, before they're ready for that, and all the things that go along with a major laparotomy. I think okay. Fingers on your buzzers. Who knows what Sheehan syndrome? Anybody? Has anybody heard of it?
No.
No.
Is that with breastfeeding? Is that?
Yeah, good.
Yeah.
It's pituitary.
Yeah.
Panhypopituitarism resulting from hypovolemia, and you can get lack of prolactin and thyroid dysfunction and all that stuff. No periods. Asherman's. Anybody?
Is that a temporary syndrome or?
Permanent.
That stinks.
Asherman's is uterine scarring from a DNC, more common after postpartum DNC. Obviously anemia. Recurrence risk is said to be about 15%. It depends a little bit on what the etiology was, if there was one. If it's acne, you're probably looking again at a recurrence risk of about 15%. So as we talked about, when they come in the door, they say, yeah, last time I almost bled to death, you want to get ready.
Oh. Anybody want to switch with me?
Come back here. Get help.
So you want a good outcome. This I'm going to pass this around for perusal later on. This is just again an algorithm for general postpartum hemorrhage and what to do, and I would be open to any questions.
You routinely take the end of the bed off up here, correct? I haven't
I do.
been back there yet, but.
We just were
I mean,
told.
if a
Where
patient,
I was
unless the
from-
patient says I don't, you know, I want to be on my side or all fours, I don't, you know, that's
Yeah.
whatever. But if
Yeah.
somebody's in a normal semi-autonomy, yes, I think the bottom.
Can I just, while I have you here, I just have a question about, we've had some of the, you know, the people that come on the weekends there, and they want to put in a Foley catheter to dilate the
Yep.
cervix. Is that's just a, because you and Andrea never do that, really.
It's a mechanical dilatation. It's like the, I mean, the one that we've got, what's that called, the Cooper or whatever it is? You know, the cervical balloon.
Yeah,
we have?
yeah. I've never
It's
used it, I don't
It's-
even know.
It's big.
Yeah, so it's just like, but do they just want to use like a Foley catheter?
Yeah.
Oh,
That's what we used. That's what I used to use way back when. But
yeah, because
the
that's.
problem with the Foley, there's
thing
two
now.
problems with the Foley. One is it's not as big as the other balloon,
Mhm.
and the other one's double-ended, double-sided.
Uh-huh.
So one's inside the uterus and one's outside the cervix. That holds it there, and it blows up to like this big.
Oh,
So you would want to use a 30 cc Foley, and it's hard to get in because it's really flexible.
yes.
On the other side of the coin, the one that we have, the cervical one we have, is nice and rigid, but it's big. It's
Yeah.
like the size of.
Like it's gonna hurt when.
Well, it's just hard to get a null, you almost always, you're talking about a nulliparous patient
Yeah.
with an unfavorable cervix, it's
Yeah.
not very easy to get in.
Well, thank God they've never done it, but they talk about it, and I think,
It's nothing different
Am I
than the
gonna
balloon
do
that
that?
we've got available,
You're not gonna
other
do
no, I
than
know, but,
the
you know,
mechanics of the device.
yeah, I
It's-
just didn't
It,
know.
it lifts the membranes, so you get prostaglandin release,
Uh-huh.
and it also, there's a mechanical dilatation to it,
Okay.
so.
So they would have to stay in bed, because that thing would probably.
Well, we used to hang a
waiting
brick on it.
Well, I'm sure you've got some of those messing around.
Well, because then you want
Cement
that
block.
inside pressure.
There's some, yeah,
Oh,
it's just a
yeah.
little bit, and then when it falls out, when the brick hits the floor, it's.
Right, yeah.
They're dilated. They're dilated.
Dilated.
Yeah, they're probably, you know, with a Foley, they'd be.
Yeah.
Well, thank you for that, I just needed to know, but
I
that's a
mean,
great idea.
and I put them
though.
in with, you can get a stylet for Foley's,
Mhm.
so it makes it a little firmer.
Oh, yeah, you could do that.
There's a stylet that they use
Yeah.
with the urologists, if you
Yeah.
have difficult catheterization, you can also get a
They
stylet.
talk about it, but yet, you know, they don't, you know, they really haven't explained to us exactly what their plan is.
It's the same as, it's the same concept as the probably very expensive device that we have back there already.
Yeah, that we're probably not gonna ever use.
With two
I
screws.
mean,
We've used it.
you know,
And the
I've
green
used
one,
it.
and
I've never
I've
used
used
it.
it.
I've
I've
never
used it.
used it.
Yeah.
Well, I'm knocking on wood, I'm sure I'll be using it.
Yeah.
It's a lot, yeah,
So we
there's
have
one
it,
back
we
there
have a
right now, we're gonna
policy.
get.
Do we
I'm
have
gonna have
a
to
procedure
find,
policy?
I'm gonna have to find it and I'm gonna have to look at it.
It's that little
I
vacuum
always
up
do
there.
too, because there's two,
Yeah.
again, there's the
Two
the
balloons.
distal balloon and the proximal balloon, and you gotta
Yeah.
fill them up like
Yeah.
this, and it's.
Nina Russell used to use it.
Yeah, well, Ina was big on those,
Yeah.
Barclay balloons
Yeah.
too, when we had anything, she used a lot, used those.
Do you have Cervidil still?
Cervical?
Cervidil.
It's in the freezer.
I think we
You
keep
do?
one.
We do.
Yeah.
Okay. That's
We
what-
used it.
Someone,
How do you-
one of the locums just
Cervical.
used it not that long ago.
Yeah.
Yeah,
I don't-
Lillian liked it.
Okay, yes.
Lillian, yeah.
How do you just, like, what's the rationale for the order in which you give the Methogen versus the Hemabate
It's,
versus the Meso?
honestly, it's just convention. I don't think there's any, I mean, you could, I mean, most of the protocols recommend leaving misoprostol till last. I'm not sure why, probably because it's less
Oh,
effective.
I've used it first.
I- In my other
It's
delivery
teenagers.
room experience, that's the one they use first all the
Yeah,
time. So I was just,
Misoprostol.
yeah, I was
Yeah.
just curious, what
Um,
is the,
We used to
they
use
each had a
6.
different mechanism, or they
Yeah.
just?
We always get Methogen first.
Yeah.
Yeah, I can't remember what they, I read an article that definitely said save misoprostol till the end. Part of it is, you should never use it vaginally, because it's just gonna get washed out.
Right.
So you have to do it rectally,
Mhm. Yeah.
which usually they recommend 800, which is
Mhm.
5
Yep.
to 8 tablets.
Yep.
Yeah.
So, I mean,
Yeah, oh no, it's unpleasant, for sure,
Yes.
but.
yes.
Well, does it work any faster, or, I mean,
I don't think it
because
does, no, and
Methogen
and the other thing
and
about
Hemabate usually
misoprostol
work
is there's a way higher incidence of nausea, vomiting,
Hemabate's awful.
and temperature elevation, that kind of stuff.
I'm just curious what the difference between.
I mean, they all work in different ways.
Yep.
So, and
Yeah,
again, you
tempo is-
certainly, don't
Yeah, somebody with a 10 would do that.
get on to the next one if
Yeah.
the first one's not working.
Yeah.
So if you give a shot of Methogen and absolutely nothing happens, then think about Hemabate. If that doesn't work, then you can go to misoprostol, but, I think the particular review thing that I read suggested that you leave misoprostol to a quarter. I don't know that there's any science behind that. Thanks for coming.
Well, thank you.
Thank you for coming.
Yeah. 12:30.
Wow, that's